disorders, a DSM-5 list in the depressive disorders category, and one is persistent depressive disorder. This one's going to be a little bit harder to appreciate, but it is probably out there more than we know and probably not diagnosed well. It is similar to the major depressive disorder, but less severe and has to be present for over a period of at least 2 years. Okay? How long was the duration of symptoms for major depressives? Or 2 weeks. So we're looking at 2 weeks, you have to have 5 symptoms out of that group, and one has to be, you know, inability to have pleasure or the depressed mood. So here you're looking at less severe symptoms, but for a period of at least 2 years. Most, and this disorder, persistent depressive disorder, you also see called dysthymia. Okay, many of the dysthymic individuals have experienced near lifelong depression. Can you imagine? There are people who actually never do operate in any mood other than a baseline depression. The diagnostic criteria: depressed mood for at least 2 years, present while depressed of 2 or more of the following. Okay, depressed mood for 2 years and then 2 more. Poor appetite or overeating, insomnia or hypersomnia, low energy, fatigue, low self-esteem, poor concentration, the difficulty making decisions, feelings of hopelessness. Okay, so it's some of the same symptoms that you had before, but for a longer period of time. They are never without the symptoms of depressed mood or the 2 or more additional symptoms for more than 2 months at a time. Never. Okay, that's feeling bad all the time. The criteria for a major depressive disorder may be continuously present for 2 years. So look at this, just to distinguish it. We've got the classic major depressive disorder can be diagnosed over 2 weeks with all the symptoms that we put together. But it is possible for a person to have a major depressive disorder continuously for 2 years. So now you have to decide, is it dysthymia because they've been in a low mood for the past 2 years, or is it actually a major depressive disorder? And the difference is the number of symptoms that you're looking at, you know, as part of that complex. They also never have had a manic or hypomanic episode, because as soon as they have mania or hypomania, they're moved into the bipolar group, and you have to think bipolar. The symptoms are not explained by another psychiatric disorder. The symptoms are not attributed to substance abuse, and these symptoms cause clinically significant distress or impairment. So it's all those same things, so you have to have your timelines down. So it's possible to have a major depressive disorder that has lasted for 2 or 3 years if you have all the symptoms for all that length of time, or if they don't have all those symptoms but fewer at a continual level for 2 years, then maybe it's dysthymia. I am not going to give you test questions that get into figure this thing out. You can answer it because you know enough to count all the symptoms, but I don't think it's actually necessarily the most relevant thing to look at, except I do want you to know the distinction of timelines and the types of symptoms that would fit in for either one or the other diagnosis. The symptoms of major depressive disorder that are not present. If you look at the list of all the symptoms for major depressive disorder, I gave you a long list, and this dysthymia had a shorter list. Here are the 4 that are not on dysthymia. So if you've got these, then it's probably major depressive disorder anyway. Markedly diminished interest or pleasure in all or almost all activities. That's that anhedonia. That's part of major depression. You didn't see that for dysthymia. They can enjoy things, they're just low mood all the time, you know, depressed mood. Significant weight loss or weight gain, not part of dysthymia. Psychomotor agitation or retardation, not part of dysthymia. Recurrent thoughts of death or suicide, not part of it. So there's not any attempt to harm, they just are depressed mood. Let's look at the last disorder, premenstrual dysphoric syndrome. Okay, now this one, in the majority of the menstrual cycles in the preceding year, the patient must have had at least 5 symptoms, must be present in the final week before the onset of menses. They have to start to improve within a few days after the onset of menses, and they become minimal absent in the week post-menses. So this is a very short-term disorder, fit very specifically around the menstrual cycle. One of the following symptoms must be present during this timeline, okay? So you got at least 5 symptoms, but at least one of them must be Marked affective lability, that's happy, sad, angry, back and forth. Marked irritability or anger or increased interpersonal conflicts. Marked depressed mood, feelings of hopelessness or self-deprecating thoughts. Marked anxiety, tension, and or feelings of being keyed up or on edge. So that has to be one of the symptoms of the 5 that are present. Okay. Now here's the rest of the stuff. One or more of the following symptoms must additionally be present to reach a total of 5 symptoms when combined with the symptoms listed above. Okay. Now if you go back here, you have to have at least one of these. You can have all 4 of them, and then you need one more to be 5. Okay, but you have to have at least one of these. Then you have to have, if you have one of these, then you have to have 4 of these. Decrease interest in usual activities, subjective difficulty, concentration, lethargy, fatigability, marked change in appetite, overeating, or specific food cravings, oversleeping, not sleeping, sense of being overwhelmed or out of control, and physical symptoms such as breast tenderness or swelling, joint or muscle pain, a sensation of bloating or weight gain. So those are all part of the diagnosis too. And so that's it. That's all we're going to do. That's that disorder. So you have major depressive disorder, persistent depressive disorder, dysthymia, or premenstrual dysphoric disorder. Okay. It's important to note, and you know that one of your symptoms listed is anxiety of one sort or another. Anxiety disorders are highly comorbid with major depressive episodes and are often difficult to tease out from depression. Okay, let me just jump over here right now. You've got to just, in your brain, you got to jump over here. I'm teaching you specific disorders, so we'll talk about the classic major depression. We'll talk about the classic bipolar 1. We'll talk about phobia, all types of phobias. In reality, you may have mixed things in the same person. So you'll have all the criteria for a major depressive disorder and all the criteria for an anxiety disorder, and they'll be together. Okay? So it's possible to have multiple diagnoses. We're kind of taught to figure out what something is, and you kind of feel like once you figure it out, that's it. In psychiatric disorders, you often are you have a constellation of bad news coming in about all kinds of things, and you have to think and sort what criteria does it meet so that you have good diagnostic codes that you're putting down for that specific person. And it's very common to have comorbid psychiatric disorders. Just like I showed you earlier with major depressive disorder, those people might be more prone to personality disorders. There's some things that can happen. So now you've got, narcissistic personality and a major depressive disorder. So there's more things going on. I'm going to teach them separate, but in the real world, there may be mixes. Okay. Assessment of patients with depression. Okay. Here's things we've kind of already looked at: appearance and affect. They can have a normal appearance. They may have a declining grooming or hygiene, but maybe not. They have psychomotor retardation and flat affect. Some may have psychomotor agitation and restlessness. So that category of assessment can be an extreme number of different things. Can be possible. Mood and thought processing content. Mood is usually sadness, heaviness, numbness, irritability, loss of interest or pleasure in usual activities, expresses being overwhelmed, thinking is negative. They always talk about hopelessness, helplessness, and worthlessness, the 3 lesses. So hopeless, helpless, worthless, and delusion sometimes but not often present. Okay. Speech could be normal, it could be slow, it could be monotonic, or it could be lacking spontaneity and content. I talk to depressed people, you ask them a question, and I like rapid fire. And I'm so what do you think about that? Well, it's like, I'm gonna wreck in the ditch talking to you because I'm going and you're not giving me enough to work with here fast enough. But it can feel that way. Here's a little mnemonic that you can keep in mind that's helpful when you're trying to pull out symptoms for depression. C, E, caps. So you want to focus on, it's done. Oh, there it is. Sleep, interest, guilt, energy, high or low, do you have it, interest, yes or no, are you sleeping, how are you sleeping, concentration, appetite, psychomotor function, and suicide. And that kind of picks off a lot of the things that you're looking for to count up your 4 or 5 symptoms that you need depending on your diagnostic category. Complaints in 5 or more areas point to a major depressive disorder. So if they give you the correct response, then you're getting there. There are questionnaires that can be used in practices, and we are actually going to work with the PHQ-9 when we do SBIRT next week. On your D2L site, I have uploaded each of these inventories for you to look at. And you might spend a little time looking at the Patient Health Outcomes 9. It's a very quick survey that can be administered in office practice. And given the frequency and prevalence of depression, a lot of primary care offices are now having patients answer a questionnaire in the waiting room before they come back, because you can quickly score it and know what you have to deal with. If you have to take all your time to gather the history, your visit is over, and you just now have come to the point of knowing, well, there's a problem, now I need to go another direction. So you'll see PHQ-9 used quite a bit, and we will use it. You'll get a practice with that in the SBIRT. Here's PHQ-9 interpretation. I am not asking you to remember the numbers. I just want you to be familiar with what it looks like when the form is done. The form usually has the scoring scale at the bottom, so anybody can administer it in total, not to get a number. But if you have scores 0 to 4, may not need depression treatment. 5 to 14 is mild. Score 15 to 19 is moderate, and score 20 plus is severe. You can see when it's mild, judgment must be used about treatment based on duration of symptoms and function impairment. They may or may not do anything with it. Moderate major depressive disorder treatment with psychotherapy, antidepressants, or both. And in a severe, it's treated with antidepressant with or without psychotherapy. And what they're saying is when you're severe, you need to get drug therapy going, because that helps the person bring up their ability to concentrate and focus enough that psychotherapy can work. It's possible to be so depressed and unable to concentrate, focus, think, or orient that you can't do psychotherapy to pull somebody out of the hole. You have to get them up out of the hole enough with drug therapy that they can then be able to respond in a meaningful way to psychotherapy. Okay? So drugs and psychotherapy actually go hand in hand, and how they are used varies among practices, but these are some general principles to look at on how you would use the two. I think psychotherapy is very helpful. We tend to have a shortage in Oklahoma, so you don't see it offered as much, and so people rely heavily on drugs around here, which do wonderful things, but they don't do all things, so they aren't definitive in and of themselves. Okay, differential diagnosis. What do you do? Okay, here's some disorders that can present with depression. Some of them you've had, some not yet. Viral illnesses like mono and HIV can present as with depression. Malignancies, GI, pancreatic. Endocrine disorders, thyroid, adrenal, you can put diabetes in there. Hematologic disorders, anemia. Cerebral vascular accidents, post-stroke and post-MI, you can see a person have depression. And it's not just because they've had a bad event happen. It may be tied into the processes themselves, that you can no longer regulate brain amines the same way after these big events have fallen on top of you. Collagen vascular diseases can do it, like lupus. I know you haven't had this arthritis and stuff. This will be coming. You've had some autoimmune disorders, I suspect by now. CNS disorders, drugs and toxins, corticosteroids, commonly used drug, a very common issue. You have to think about depression with long-term steroid use. You can also have euphoria. So there's some people who like the high of steroids, but there are other people who actually go get depressed. Some antihypertensives, particularly the ones that work in the brain. Can y'all name me some brain antihypertensive drugs? Say it again. Mannitol is a diuretic, and it can be used. It can get, but I'm thinking more for hypertension. Propranolol would be one. Beta blockers are central workers. Clonidine is in the brain. Do ACE inhibitors get in the brain? No. Do calcium channel blockers go in the brain? Not really. Okay, there's some nuance to that, but let me just say for right now, that's not really what you're thinking about. Do diuretics get in the brain? No. Except there's with it, but for antihypertensives, the advocated drugs, you're usually looking at the ones that work centrally, and that's beta blockers and clonidine are probably your big ones. Okay, sleep disorders can present with depression. Here's a whole list, I'll put them down there, and so even beyond the centralist, calcium channel blockers are on the list. Clonidine, interferons, histamine 2, corticosteroids. Did y'all have procainamide when y'all did arrhythmias? It's an oldie but a goodie, but probably mostly an oldie. Okay, indomethacin, a non-steroidal, an older one, barbiturates, and narcotics. History, you want to evaluate for family history, depression, and mental disorders because they tend to be in families. That genetic link, neurologic illnesses, exposure to certain pharmacologic agents, chronic pain, illnesses, psychosocial stressors, all those things will be part of the background history. Do you order all these tests when you have a patient with suspected depression? No, not really. But you would if you had other issues you were trying to sort out, or you might look at some of these. So CBC could be an infection, which could be part of the picture. TSH, hypothyroidism, tends to have a lot of depression attached to it, so you might screen that. ANA, have y'all had ANA yet? Anti-nuclear antibodies for autoimmune disorders. Y'all had this for inflammation, ESR, separate. B12 could be a B12 anemia. You get a lot of neurologic complaints. You can have depression. Y'all remember back into hematology genetics, or are you trying to forget that? Okay, you know, B12 deficiencies have neurologic symptoms. The RPR, you get down to sexually transmitted diseases, HIV, CMP, blood alcohol, tox screens for other agents, blood gases, dexamethasone suppression tests. I'm not going to get into asking you what you would order at this point, but I will tell you, in psychiatric institutions, hospitalizations, they usually have a standard workup. And most standard workups for psychiatric patients are a CBC, a thyroid hormone, B12, CMP. They'll do a tox screen, and that'll be about what you'll see. That's just kind of the basics. So they're screening out for the basic high yield things, and then based on history and other background, may go other directions.
What's in the tox screen?
The tox screen varies. It could be marijuana, all kinds of, LSD, amphetamines, just the street stuff is what you see. And the toxicology screens, different companies put different things in there, and providers can often mark off what they want. They can get the full panel, or they can go for certain things. So the tox screen is looking for usually illicit stuff. You also can, on a tox screen, you can ask for heavy metals and things like lead, iron, just different things you can look at that might cause problems. Treatment options. We'll give you an overview of treatment options, and Dr. Latassi is going to go into more detail, but I want you to have the big picture of it. Okay, there are 4 areas that we look at. There's FDA-approved antidepressants, there's psychotherapy, there's electroconvulsive therapy, and there's over-the-counter or herbal remedies. So let me just make some broad statements about these. The antidepressant options that you have SSRIs, the selective serotonin reuptake inhibitors. You have the serotonin norepinephrine reuptake inhibitors, the SNRIs, the monoamine oxidase inhibitors, which I think I've already heard that because this interacts a lot, and tricyclic antidepressants, the TCAs. So those are your categories. Mostly this world is the first 2 drugs. You'll see this more in primary care practice. MAO inhibitors and tricyclics. You'll see tricyclics around, but most have moved to the SSRIs. Monoamine oxidase inhibitors can be used, but you tend to see those be used by psychiatrists for atypical depressions and those that don't respond, so it's not usually something that you're going to be dealing with in your ballpark. Psychotherapy has been shown to be at least effective as medications to treat mild to moderate depression. Okay, so it can be helpful at that level. May be used in combination with antidepressant drug therapy. So it can be a standalone for mild to moderate, but it can be used as an adjunct of drug therapy in any category, with the exception of the major, severe. And then as severe gets better, you can still look at psychotherapy. Electroconvulsive therapy. My friend actually had ECT, and this person had the major depression off and on in life for quite a length of time. And the last episode that this person had was so significant that we were really concerned about suicide. And hospitalization happened, and inside the hospitalization they did ECT. And we went to see this person after the ECT. Have you ever seen a person after ECT? Have y'all had anybody, is anybody here maybe somebody who's had ECT? You don't see it done very often, and I'm going to talk to you again here in a second about who are candidates for that. But after that had been done, I almost did not recognize, by face, yeah, I knew it was there was a person, but the look was so different, the expression was so different, just very dead looking, almost, just very little emotion whatsoever. Looked very wrung out, very tired, very much psychomotor retardation, was unable to move, normally. And so it was really kind of creepy. We went in, went to talk, and that was all really good. They recognized us and everything was okay that direction, but there was a lot of shame in having had it done, number one. And then also just the inability to be so spontaneous. This person was just a live wire, bubbly all over the place. And when you see this, it's such a contrast that it scared us a little bit. But recovery happened, and doing well as far as I know. Moved eventually to Louisiana, so I don't get to see this person all the time. Sometimes it's used for patients with major depression unresponsive to antidepressant therapy and psychotherapy, and that was the case for this individual. It's sometimes used when patients pose a severe threat to themselves or others, and you cannot get them stabilized enough soon enough with drug therapy to keep that person from actually doing some harm. Okay, OTC and herbal therapy. There's all kinds of stuff. Y'all ever walk in the health food stores? Y'all go looking around, just looking on. I like to go look and see what's out there and see what your patients are going to come in here and talk about, what's on the shelf right now. And there's all kinds of things. Some information about these agents is positive, but we really don't have good studies. There's a lot of side effects that can happen from there, and there are drug interactions that can happen too. So I'd say they're mostly still understudied. St. John's Wort has a good bit of information. You see stuff about the SAMe, that S-adenosylmethionine, omega-3 fatty acids, saffron, and the 5-HTP and DHEA. When you go look at it, it's just not real clear that they are helpful. The studies are so poorly put together, and the comparison groups are so poorly done that when you get through reading, it's like, I don't know, it's not good. So the data is not great. The goals of treatment. The ultimate goal is to return the patient to a fully functional status and a good quality of life. You have to know with depression that a person you're looking at long-term treatment relationship. How are you doing? And you have to just kind of keep watching this. It's a relationship over a long period of time that will have its ups and downs. Barriers to treatment. There are some significant barriers to treatment, and in this state they are there for sure. Adherence. Look at this, 25 to 30% of primary care patients treated with an antidepressant medication discontinue within 1 month. Okay, 1/3 of people are out of the ball game at the end of 1 month, and then 40 to 50% within 3 months. So half the people you've seen aren't even taking the drugs. That's why if you start an antidepressant and say return to clinic in 6 months, you might basically have a person who 5 months is untreated because they quit early on. So I feel like when you're starting pharmacotherapy in some of these disorders, you're better served to have the person return within the month to evaluate, can you use it, are you having adverse effects, and to evaluate responsiveness so you can make some course corrections. If you just prescribe and then they never come back, you can miss a lot, and you see how much is negative is happening in gap. Finances, insurance are huge problems. Even if you had Medicaid, they have limits on which ones you can get and how much you have to pay to even get those. Then physician-provider communication. There can be, I really think I meant to put patient-provider communication. It's the communication between the patient and the provider maybe not often enough or connected enough to have the therapeutic relationship that you need to see the outcome that you wanted to get. Reasons for treatment failures, and there's a good number. Limited time in primary care practices to arrange for mental health referrals. That happens. You have so little time, and by the time you think something's going on, you don't have more time to assess it, and you don't have time to make the referrals, or the patient doesn't have eligibilities for referrals. Patients' unwillingness to see a mental health professional. A lot of people won't go see it. You think I'm crazy? And in the world, anybody who's being referred for psychotherapy or counseling or whatever, in the world at large, there's something wrong with you. And if you are seen doing that or you say you're doing that, then you get a stigma back on you by everybody else around you. And we really actually have to help take that wall down because people are not getting care. Regional lack of availability of mental health professionals. Jessica, do we have a problem in Oklahoma?
Yes.
Oh gosh, it's just we're so underserved and we're also underfunded. Oklahoma doesn't put a lot of money into mental health. Physicians' concerns about stigmatizing patients by sending to the shrink. Sometimes the provider knows that you get labeled, and so they like the person, they don't want to label them, so they just kind of try to do things without going for the full treatments available. Patients' concerns. Okay, so here's the conclusion on depression, kind of as a big ball of wax. Highly prevalent condition, a lot of morbidity and mortality. Primary care providers are in a unique position to diagnose and manage it. The use of patient-completed questionnaires can help you initiate the process along with careful evaluation for other causes. The primary care provider may begin treatment, often working together with a mental health professional if you have a good relationship set. And then antidepressant medication and or psychotherapy can lead to remission in a large percentage of cases. So there's real possibilities. So knowing it's out there fairly commonly, knowing how to identify it and diagnose it correctly, and how to initiate the treatment path with psychotherapy or medication or both with appropriate follow-up gives that person their best chance to recover. Okay? Okay, so let me just stop right there and ask you if you have any questions about that before we move over into the bipolar things. I have a video clip of the bipolar woman. She is so fun. I can't wait. Yes.
In light of recent events concerning our laws, is there any evidence at all that THC can help treat depression?
THC and depression? Yeah, I noticed that. There is information. Is it helpful?
Well, I mean, is there any evidence-based medicine that if you prescribe marijuana for someone, it will help treat their depression? Is there any evidence at all?
There is evidence. Whether it will be, here's what I think is interesting. Is the evidence great? No. There's some out there. Anecdotally, yes. Will it make the list of conditions that can receive medical marijuana in Oklahoma? I don't know. The health department's putting that together now. If they will clearly put nausea, antiemetics and chemotherapy. They'll put it in there for glaucoma. There's some disorders that we know about. There's others that are less known. So it depends on how liberal that group is. I would suspect in Oklahoma it will be a tight list if politics can intervene. I'm not for anybody or anything. I'm just saying I think that probably it will come in more limited. Otherwise, people will say it's wide open and it's just really recreational use coming in the back door of authorized medical use. But is there evidence? Yes. Is it great? No. Will it get on the list? I don't know. I think the answer is going to be no, but that's just me. I don't have any power over there. Okay, and I don't want any either. All right, let me go to bipolar. Let's see, we're definitely connected.